Thank you, Team Manipal and Ayyappan for inviting me here. This talk is on calcific tendinitis, suprascapular nerve compressions. And as we know, the suprascapular nerve is from the C5, C6 superior trunk, travels through the posterior triangle of the neck and enters into the supraglenoid notch. There it lies under the transverse scapular ligament, and then it gives a branch to the supraspinatus. Then it goes down behind to the spinoglenoid notch. After crossing the spinoglenoid notch, it gives away a few branches into the infraspinatus, and it ends there. So this is the course of the suprascapular nerve. So the nerve can get compressed in two places, one in the spinoglenoid notch and the other in the supraglenoid notch. The spinoglenoid notch is usually with a posterior labral tear or a slap tear, like in the MRI you saw. Arthroscopy will show a posterior labral tear like this. The next step, this is a surgical video because Ayyappan wanted me to keep it completely surgical. So you will make your accessory posterolateral portal. Depending on the site of tear and the site of the ganglion cyst, you can vary your posterolateral accessory portal. So that will give me a good trajectory to decompress and also repair the posterior labrum from there. Now I'm viewing from the anterior anterosuperior portal, and gently bring in your elevator and rasp. Have a rough idea of where the ganglion is and go on to decompress the ganglion. Since this acts like a space-occupying lesion sitting on the suprascapular nerve, decompression of this ganglion alone is enough. You have to be extremely gentle to not go and push your rasp and other instruments onto the nerve itself, because the idea is to decompress the ganglion which is compressing the nerve and not go and dissect the nerve or damage the nerve further. Through this, you can go and bring out all the ganglion cyst. This was a doctor who was 49 years old, had an injury while doing yoga and developed a tear. He's been living with this for some time, and you have to make sure that mucinous material like this is coming out of the cyst, which again tells us that the cyst is thoroughly decompressed. The other tip is to put in your shaver without your inner sleeve of the shaver, because you don't want to go and run your shaver there, but just gently use it to suck things out and suck the debris out without running the shaver. So take out all the cysts. Usually these are not septated, but if they are septated, as in the MRI, take care of them. Then go ahead and do an airtight repair of the labrum which was liberated to take the ganglion out. And the second place where this can get compressed is in the supraglenoid notch. You can see isolated supra and infra fatty infiltration in these MRIs. And unlike the other patient who had only infraspinatus loss, you have loss of muscle both in supra and infra, and do the Lafosse stretch test to recreate the symptoms. Here I'm seeing from the anterior portal, that is your CA ligament. If you trace the CA ligament, you go to the base of the coracoid, that is the base of the coracoid. You see your conoid and trapezoid ligaments, here they are. And as you traverse through them and follow them, you will go to the supraglenoid notch.